Hello and welcome to the online lecture on the transactional model of stress and adaptation. This lecture will emphasize the components of the theoretical model integrated into your clinical assignments, as well as some of the lecture content. The stress and adaptation model was originally developed by Lazarus and Volkmann in an attempt to capture all of the components associated with the experience of a stressor. The model can serve as a framework for understanding psychiatric illness and can assist in organizing the features of psychiatric illness for better understanding. Let's take a look at each component of the model in more detail. Before even looking at the stressor and how the individual appraises it, let's take a look at some of the features that may alter resilience and make the individual more susceptible to a stressor. Here I'm referring to predisposition. Predisposition includes risk factors that influence the type and amount of resources the individual can mobilize in order to handle stress. Let's use the example of a past history of physical abuse. A past history of physical abuse will make an individual susceptible or predispose the individual to a stressor that may reflect the past physical abuse. So this individual may be more susceptible to verbal or nonverbal cues that may indicate impending harm compared with an individual without a past history of physical abuse. Predisposition can be broken down into three categories: biological, psychological, and sociocultural. These are all areas where an individual may develop some degree of susceptibility to a stressor and ultimately psychiatric illness. Most of these areas are relatively straightforward. However, I'll further define some of the psychological predisposing factors for clarity. In terms of development, an individual who, for instance, is fixated in the phase of identity versus role confusion will have difficulty developing and fostering interpersonal relationships. This is because the achievement of identity is a prerequisite to the development of a relationship. In other words, if you don't know yourself, it's hard to know others. Problems in this area resonate well with conditions such as borderline personality disorder and the majority of the dissociative disorders. Personality, according to the psychoanalytic perspective, is fully developed by the age of 12. Any aberration in the development of personality can predispose the individual to alterations in stressor appraisal as well as psychiatric illness. Object relations refers to the individual's relationship with objects. Objects can be living or non-living and often represent the earliest formed relationships. In a way, objects become a part of the individual. Let's take a look at an example. Males often naturally have a strong relationship with their mother. The individual's mother becomes an object that is stored deep within the unconscious mind. As the male ages, he finds a mate. Oftentimes this mate, as well as interactions between the male and his mate, are a reflection of patterns established with the original object, i.e. his mother. This is where the idea, the way you treat your mother is a sign of how you will treat your bride, comes from. Let's take a look at this same example and look at it from a more pathological standpoint. Remember I said that the object becomes a part of the individual. Let's say that the male in our example experiences the death of his mother. If the male does not develop appropriate boundaries between himself and his mother, the male will then begin to feel as if he has lost a part of himself. As a defense for this object loss, the individual internalizes the lost object unconsciously in order to hold on to it. The individual will then begin to direct all of the fluctuating and sometimes ambivalent feelings associated with the stages of grieving inward towards the object. When this feeling is predominantly anger, the individual develops self-loathing and ultimately depression. Later, as this continues, according to the psychoanalytic perspective, the individual may develop suicidal ideation. This becomes an effort to destroy the internalized object to alleviate the feelings of self-loathing and depression. Attachment often comes along with object relations and refers to the degree of attachment between yourself and other individuals. The way predisposition can be assessed is through the collection of a past history, developmental history, and social history. Know that other portions of the history may leak into or illuminate predisposition. The next portion of the model is precipitation. This refers to stimuli that are perceived as challenging, threatening, or demanding to the individual in some way. This is essentially the triggering event or the stressor itself. The precipitating stressor can be expanded upon by considering the nature, origin, timing, and number of stressors. You may gather some information about this while constructing a history of present illness. For instance, the individual may be experiencing depression, and you notice that the patient has a high number of recent stressors, such as the loss of a job, death of a relative, financial strain, and interpersonal relationship problems. Remember that a stressor acts as the trigger for neuroendocrine activation. Precipitation is the moment where neurological and endocrine mechanisms unite to mobilize biological reserves in order to address the stressor. When in the face of a precipitating stressor, an individual will unconsciously determine whether or not there is stake in the matter. If there's a possibility that the stressor can lead to a threat, challenge, or loss, then the stressor is deemed to have motivational congruence. From a biological standpoint, the reticular activating system is activated, and motivational and arousal mechanisms are initiated. This is the moment where the individual moves from unconscious to conscious, with the more conscious portion being primary appraisal. It's important to note that there is not always a shift from unconscious to conscious here. As for example in generalized anxiety disorder, in this case the individual has difficulty directly identifying the stressors. If there is no stake in the matter, then there is motivational incongruence, and the stressor is more or less brushed off. The next part of the model is primary appraisal. This involves the recognition of the stressor. The individual will determine meaning and understanding of the impact of the stressor and evaluate the significance of the event. Primary appraisal can be broken down into several subcomponents. The first of which being cognitive. Here, the individual explores the impact of the stressful event, the choice of coping patterns used, and the person's reactions. Essentially, in the cognitive domain, the stressor is identified as a threat, challenge, loss, or potential harm. In the affective domain, emotions and feelings are aroused as a result of the stressor. In the physiological domain, the individual experiences the effects of neuroendocrine axis activation. For instance, they may experience palpitations, diaphoresis, tachypnea, and restlessness. Ramifications of immune function are also part of this domain. Chronic stressor exposure, through the result of cortisol's interference with the adaptive immunity, can result in increased susceptibility to infectious disease and autoimmune disease. In the social domain, responses are often based on the search for meaning, social attribution, and social comparison. The individual will attempt to find meaning for the stressor in order to fit the stressor into their worldview. Social attribution refers to the association of a stressor with an individual. Essentially, am I stressed out due to something that someone did? Social comparison refers to the exploration of how other individuals respond to the stressor. The behavioral domain is a result of the preceding responses and can be divided into 4 phases. The first phase involves behaviors that change the stressful environment or allow the individual to escape from it. The second phase involves behaviors that allow the individual to change the external circumstances and their aftermath. The third phase involves intrapsychic behaviors that serve to defend against the unpleasant emotional arousal. The fourth phase involves intrapsychic behavior that helps one come to terms with the event and its sequela by internal readjustment. Something to keep in mind that is not directly integrated into the model is perpetuating factors. These are factors that maintain the stressor and can include the environment, the individual, a group, a medical condition, or psychosis. For instance, let's say that the individual continually experiences behavioral symptoms of a stressor, for instance, agitation, restlessness, and insomnia. But these symptoms only occur in the home environment. The home environment would then be considered a perpetuating factor that maintains this stressor. This would clue the psychiatric practitioner to explore attachments and interpersonal relationship issues that may arise from the home environment. The chief complaint, history of present illness, review of systems, and the patient's perceptions assessed by Fife all illuminate the areas of precipitation, motivational congruence versus incongruence, and primary appraisal. Secondary appraisal is the exploration of coping resources or protective factors. These are options or strategies that help the individual determine what can be done, as well as what is at stake. There are several areas of secondary appraisal where resources are explored by the individual, including problem-solving skill, knowledge, social skill, spirituality, material assets, and developmental milestones. The second portion of secondary appraisal is the mobilization of these resources. The ability to mobilize resources is highly dependent on the availability of resources. In the following slides, I'll describe different foci for resource mobilization. The first is problem-focused. This includes tasks and direct efforts to cope with the threat itself. Examples include negotiation, confrontation, and seeking advice. The second is emotion-focused coping, where the individual is oriented to moderating emotional distress. This is best explained by the use of defense mechanisms. The third is cognitive-focused coping, which involves attempts to control the meaning of the problem and thereby neutralize it. Some examples of cognitively focused coping include positive comparison, where a more optimistic view is integrated into the stressor, selective ignorance, where the individual chooses to avoid knowledge of particular aspects of the stressor, and devaluation of desired objects, where the individual cognitively decreases the value associated with the desired object. Let's say, for instance, you really want a new kitchen table. If this brings a significant amount of stress, maybe financial, then you may begin to tell yourself things like, it really doesn't match the rest of the furniture, or it may take up too much space. Physiologically focused coping involves the moderation of physiologic responses in an attempt to control the problem kinesthetically. This includes individuals who would prefer to work out in order to manage stress, or do something hands-on in order to cope with the stressor. The ego and self-concept resonate well with the area of secondary appraisal. Self-concept includes the values, beliefs, and ideas that contribute to a person's self-knowledge and relationship to others. This determines your perception of personal characteristics or abilities, interactions with others in the environment, and values associated with experiences, goals, and ideas. Self-concept is consistently compared with the ideal self, which is the self you want to be. This should sound very familiar in considering the relationship between the id, the ego, and the superego. The ego is essentially the self-concept, in a constant battle with the id, which you could say is the ideal self, and the superego, which includes the external demands, constraints, rules, etc. placed on the individual. The ego includes innate capacities that facilitate an individual's ability to adapt to his or her environment. These capacities include perception, attention, memory, concentration, motor coordination, and language. Under normal circumstances, these capacities develop into the ego functions and have autonomy from the libidinal and aggressive drives. Listed here are the 12 ego functions. Alterations or poor development of these functions produces maladaptive coping. Judgment refers to the appropriateness or consequences of behavior. The individual must have the capacity to act responsibly. This process includes identifying possible courses of action, anticipating and evaluating likely consequences, and making decisions as to what is appropriate in certain circumstances. Reality testing refers to the differentiation of self from others and the appropriate assessment of external events. Negotiating with the outside world requires the individual to have the capacity to accurately perceive and understand stimuli. Distortion in this area of functioning results in delusions and hallucinations. Affect and impulse control refers to both the ability to modulate feelings without being overwhelmed, self-control, and the ability to delay gratification. The individual must have the capacity to manage aggressive and/or libidinal wishes without immediate discharge through behavior or symptoms. Interpersonal function refers to the ability to sustain relationships despite separation or hostility. This is sometimes referred to as object relations, or the capacity for mutually satisfying relationship. The individual can perceive himself and others as whole objects with three-dimensional qualities. Thought processes refers to attention, concentration, memory, language, and logical thinking. In stressful situations, thought processes become disorganized. Adaptive regression in the service of the ego refers to the individual's ability to relax ego control, allowing for creative perceptual or conceptual integration to increase adaptive potential. Defensive functioning refers to the ability of defense mechanisms to prevent symptoms without becoming maladaptive. A defense is an unconscious attempt to protect the individual from some powerful, identity-threatening feeling. Stimulus barrier refers to the awareness of sensory stimuli without the development of sensory overload. Autonomous functioning refers to both cognitive or motor functioning as well as routine behaviors being free from disturbance. Synthetic integrative functioning refers to the integration of contradictory attitudes, values, affects, and behaviors. This enables the individual to think, feel, and act in a coherent manner. Mastery competence refers to the ability to perform consistently with the individual's existing capacity. Finally, object constancy refers to the ability to provide for oneself in the absence of a caregiver. Secondary appraisal can be assessed by social history, including education, living situation, social support, socioeconomic status, identified coping mechanisms, spirituality, etc., as well as ego function and ego defense mechanisms. You'll recognize that other areas of the history and physical explore this area as well. There's no precise and definite categorization. When you conduct a mental status examination, often the signs and symptoms you see are a result of maladaptive coping. Adaptive mechanisms resonate with normal areas of mental status examination. After the individual is exposed to a stressor and mobilizes a coping mechanism, the process is evaluated. This process is referred to as reappraisal. Coping self-efficacy involves beliefs about capabilities to produce designated levels of performance that exercise influence over events that affect our lives. This is essentially a product of reappraisal. The perception of self-efficacy during the reappraisal process correlates well with self-esteem, which is the personal judgment of self-worth based on how well behaviors match with the ideal self. If an individual feels they're competent, then high self-esteem results. On the other hand, if the individual feels inferior in the face of stressors and their mobilization of coping mechanisms, low self-esteem develops. If the situation has been deemed to be ineffectively managed, The process will return to primary appraisal. From the perspective of this model, psychiatric illness is a reflection of fixation in an unending cycle of motivational congruence, primary appraisal, secondary appraisal, coping, maladaptivity, negative reappraisal, motivational congruence again, and so on and so forth. Through a thorough and accurate history and mental status examination, areas of this model can be identified in order to assist in breaking the vicious cycle.